to receive AUA and to receive Dr. J.Denstedt. Urological surgeon in London. I precise not London in England, but in Canada. He's secretary of the AUA, and he's a pioneer in the treatment of lithiasis at AUA, a great expert in flexible erythroscopy. He participated in the manufacture of stone basket. On behalf of the Moroccan Urologic Association, I thank you for your collaboration and sharing your experience with us. We also have with us Professor M.Lezrek Mohammed, urologist surgeon, specialist in peritoneal surgery. For me, I would say Professor M.Lezrek and peritoneal surgery like two fish in water when he practices. I thank our two moderators, Professor I.Sarf and Dr. Z.Aboulfadl. I thank our sponsor AstraZeneca and Mr. Manouzi, our IT. Entre parenthèses, pour les urologues qui ont des difficultés en français, il y a une traduction simultanée sur la page WhatsApp, partage d'urologie. À vous, messieurs les modérateurs.
Okay, so is there any word from your side, John, as an introductory words for the cooperation between Moroccan Association and the UAA? Please go ahead. Okay. Before you're taken down to your presentation, please.
Yes. Well, thank you.
Yeah.
You can hear me okay?
Sure. Yes, it's good.
Right. Good. Well, thank you for the kind introduction, and thank you for inviting me to do this webinar with the Moroccan Association. The AUA greatly appreciates your support and your membership in our organization. You know, I've worked with the AUA for many years. It's a great organization. They do an excellent job with education and have many, you know, different valuable benefits for the members of the AUA. Journal of Urology, the guidelines, education sessions like this, and of course our annual meeting of the AUA, which is the biggest urology congress held every year in the world. Of course, this year, because of the coronavirus situation, we had to cancel a meeting in Washington. But as of today, we're still planning to have our meeting next year. We'll be in Las Vegas, you know, very exciting city in the United States. And we look forward to welcoming as many of you as possible to the meeting. We do know we've had a conflict the last few years with Ramadan for, you know, with
previous 2 years. Yes, you have some problem, but now I think it's okay.
And, you know, we have heard the feedback on that. So we're now proactively, we look to try and avoid that conflict. So next year, we're actually clear of that conflict. So we don't overlap with the Ramadan. But again, I greatly appreciate the invitation to be here. I'm looking forward to an exciting session here on kidney stones. And if you're ready for my talk, I'm ready to get started.
Yeah, John, you will be tackling the issue of RS for renal surgery and what are the limits. So John, go ahead with your presentation. We're listening.
So do you see my slides? Do you have my slides?
Yeah, it's okay.
Okay, good. All right, so what we'll talk about today is basically flexible ureteroscopy for treating stones in the kidney, otherwise known as RIRS or retrograde intrarenal surgery. But really that means flexible ureteroscopy for treating stones up in the kidney. And just, you know, thank you again for that introduction, just to show you where I am. So I'm actually in Canada, And in London, much smaller than the real London. In the UK, we're a town of about 400,000 people in southwest Ontario, here in Canada. And as I think you probably all know, Canada looks just like this for 6 months of the year, covered in snow and very cold. But right now we have the summer. It's beautiful outside here, and it's a great time of year here in Canada. So if we think about the treatment of kidney stones, things changed very significantly with the advent of the shockwave machine. So shockwave lithotripsy, about 40 years ago that was first described by Christian Chaussy and the colleagues in Munich in Germany. And, you know, initially this looked like almost a miracle kind of treatment, very non-invasive. Patients were very attracted to it. But now we know that there are many factors that decrease the stone-free rates and the success rate of the shockwave machine. And I won't go into all of these in detail, but things like obesity, which we have a lot of here in our country and in the United States, renal anomalies, and some stones are just too hard to break up with the lithotripter. So now we know that the success rates are much less than we thought they initially would be when Chaussy invented the shockwave machine. You know, everybody's trying to improve the results with shockwave, and this is just an example recently from Korea of using artificial intelligence and machine learning, which basically plugs in a whole lot of factors, Hounsfield unit density, size of the stone, location of the stone, to try and select better which patients might do okay with shockwave. If we look, and this is from the AUA guidelines, and the first iteration or example of our guidelines really never talked about ureteroscopy for treating small stones in the kidney. But the more recent guidelines now really tell us you have two choices to offer the patients, shockwave or ureteroscopy. So that's a big change in the guidelines, where we now can offer ureteroscopy, and many institutions, even our own, will offer ureteroscopy ahead of shockwave lithotripsy, even for smaller stones in the kidney. And we'll look in more detail about why that is. You know, for larger stones bigger than 2 centimeters, it is preferred and in the guidelines to do percutaneous stone removal. But really the title of this talk and what we'll look at today is ureteroscopy is now being extended to larger stones up in the kidney in certain patient populations, and the indications are increasing and encroaching, if you like, on percutaneous stone removal. So there are some patients, even with larger stones, where ureteroscopy is a good choice. You know, people with abnormalities of body habitus, you can't get them positioned for percutaneous, anomalies of the kidney, so some renal anomalies, very hard to get access, and patients on anticoagulants represent a very good indication for ureteroscopy. And we were the first to talk about doing ureteroscopy on fully anticoagulated patients. So, you know, our thought at the time was ureteroscopy is so non-invasive now. It's the same as doing a retrograde, that we could go ahead with the operation, do not stop the anticoagulants, and still treat the stone. Unlike shockwave percutaneous, you have to stop anticoagulants. So now it's in the guidelines again that in patients on anticoagulants, and there are many, many patients on these drugs now for all sorts of different reasons, atrial fibrillation, blood clots, and so forth, the ureteroscopy now is the first line choice of treatment in patients who are anticoagulated. I mentioned already obesity, which is a big problem in our population, and ureteroscopy, it doesn't matter how big the patient is, it's still the same operation. It doesn't change, it doesn't get harder to do, unlike percutaneous surgery, which can be a more difficult operation in the obese patient. So in this series, they looked at efficacy of ureteroscopy, and it was very good in obese patients. So that's often another good indication for ureteroscopy, with good stone-free rates and very low rates of complications. Anomalous kidneys, where it might be difficult to get a percutaneous tract in, things like horseshoe kidneys, pelvic kidneys, ureteroscopy could be a good choice ahead of PCNL. So, we can talk a lot about guidelines and so forth, and we know people don't always follow the guidelines, and sometimes things just happen. So these are trends here in kidney stone treatment in my province of Ontario, where we have a very good database of healthcare treatments and procedures and so forth. And this is what's happened over the last 20 to 30 years. The blue line is the number of shockwave treatments, and the red line is the number of ureteroscopies that are done in our population. So big decline in shockwave and a big increase in ureteroscopy. And percutaneous surgery is kind of flat, around 10% of all the cases. And this same graph could be seen almost anywhere now. Australia, the UK, Denmark, Germany, there are similar publications about this profound trend in the treatment of kidney stones. But back to my original question, what is the limit, of ureteroscopy? This is a plain film, huge staghorn stone, and I'm sure we would all agree this could not be treated with a 2mm ureteroscope. The stone is just too big. We can't treat all of that in a retrograde fashion. Patient needs a PCNL. Same thing here. This is a plain film, huge bilateral stones. I did percutaneous here on both sides, and there's too much stone there to treat with the ureteroscope. So, where is the limit between 2 centimeter stone and these huge stones? And that's what we're going to look at here in more detail. Of course, the increase in ureteroscopy, a lot of it has been propelled by technology. So new good instruments like the ureteroscopes here, digital scopes, and also the use of the laser. Now we have disposable ureteroscopes. And obviously there's a cost associated, and we'll talk a bit more about the cost of these instruments, but it gets around all of the repair costs and everything else that goes with our usual reusable ureteroscopes. A lot of information here, we won't go into it in detail, but there's many companies now making these disposable instruments, a lot of them coming from China, actually, and the cost hopefully will come down as time goes on. So with the disposable ureteroscopes, the information we have is that they perform as well as our usual capital equipment, like from Olympus and Storz and so forth. And you've got good visibility, good deflection, and overall the instruments perform very well and will give you the same results as with the usual instrumentation. Again, the cost is the big issue with these, but very interesting in this study done in San Francisco. They compared the cost of reusable scopes versus disposable scopes, and interestingly found the overall cost is the same when you look at repair costs and cost of sterilization and all of that things. So it depends on your healthcare system and your hospital, but sometimes the cost may not be quite as much as you might think. The other thing that people are worried about is throwing away all this medical equipment. It goes in landfills. It's not good for the environment, and all this plastic that we throw away. But again, very interesting, they compared here the carbon footprint, so the environmental impact of reusable scopes and disposable scopes, and interesting enough, it looks like they're about the same, actually, when everything is factored in. The other big advance in technology, of course, is the laser. We treated the first series of humans with the laser here at my hospital, the first human beings, and we knew right away it was going to be a very good tool. This was the very first small series we published, 23 cases, and immediately we could see the holmium laser, which is still the standard of care for lithotripsy through a scope. It was an excellent instrument. Holmium laser is still evolving. We now have what's called the Moses technology, which refer to Moses because of parting of the waters. So it's a kind of a dual pulse arrangement where initially with the first pulse, the water is parted, and then the second impacts on the stone. and it may increase the efficiency of the holmium laser. We're still waiting for more information on this, but the early results look encouraging. The other laser, which I think we'll all start to hear more about, is the thulium laser, now being used for treating stones. And Olivier Traxler in Paris, France, who I'm sure many of you know, has done a great job of investigating this and doing the early series. I've used it myself in India, actually, a few months ago, and I was impressed with the efficiency in breaking of stone. So we'll start to hear more about thulium and thulium fiber lasers over the next year or two. And it seems probable it will become very competitive with the holmium laser. Other equipment has evolved further, includes access sheaths, so a tube basically that you put up the ureter to facilitate the procedure. There's some debate about whether this improves stone-free rates or not. Some studies show no difference in the stone-free rate if you use a sheath or don't use a sheath. I will tell you, I only use it in about 10 to 15% of our cases. I don't use it in the ureter. I will use it for a larger stone up in the kidney. Around the world, though, it's pretty common to use access sheath. This survey of Endourology Society members shows that half the people used it, as a routine in all stones and found it to be a useful tool. Well, that's more than in our hospital, but it gives a sense of where that fits in. The other thing to talk about is complications, and this is from Olivier Traxler, and I give him great credit for advancing this whole concept of the use of the ureteroscope. And his overall complication rate in over 1,000 patients was 15%. Now that seems high, but many of these things we often wouldn't consider a complication, like stent symptoms. That unfortunately goes along with ureteroscopy. You have a stent and you have discomfort. So really the serious complications were very low, in the range of 1 or 2%. But just to highlight that although ureteroscopy seems like a very minor procedure to us, maybe not too much more than cystoscopy, it can come with some very bad outcomes. These are rare, fortunately, but here's a series of life-threatening complications after ureteroscopy. We think it's a simple operation. So some nephrectomies, a lot of these were bleeding around the kidney, perinephric hematoma. So, even in a small procedure, bad things can happen. Sepsis is the other thing to be aware of. And in the CROW series, which was a very large series, close to 12,000 patients, there were actually 5 or 6 patients who ended up with mortality after, sepsis due to ureteroscopy. So you're working in a closed system with the ureteroscope. So with bacteremia and so forth, obviously infection should be treated before you do the procedure, positive cultures, but we have to be aware of sepsis as a complication. These pictures have sort of become famous from Olivier, and it shows injuries to the ureter from an access sheath. So it really emphasizes the importance of very gently putting an access sheath up. Don't force it or you will rupture the ureter. And of course, none of us want our ureters to look like these ureters from injury from an access sheath. Interesting enough, this is a more recent paper that looked at some of those severe injuries, and the stricture rate of the ureter, which is the final outcome of anything bad that happens in the ureter as a stricture, may not be as high as we think. And this shows that even with bad injuries, quite often the ureter can heal up. It's a resilient structure, it appears. So although strictures can happen, fortunately, they don't happen as much as we think they would. Now, this is a very recent paper again. I think obviously engineering will continue to improve all of these instruments. And we're probably going to start to see access sheath with the suctioning ability. So you fragment the stone and then suction the sheath through the access sheath. So it's a very recent paper, and we'll start to hear more about this. Just a couple of other possible advantages, particularly in larger stones for an access sheath, is that this decreases the pressure in the kidney when you're working. So pressures on the side, maybe sepsis will be less if you use an access sheath. But if we're doing longer cases with an access sheath, there's also a bit of concern about getting a stricture because of ischemia of the ureter. So it's very tight on the access sheath. Maybe it will affect ischemia and then a stricture. So it emphasizes the point of not to work too long, and I'll touch on that again here in a minute. You know, the main outcome though that we look at in any stone treatment is the stone-free rate. So there's a lot of information, but the thing in the top right, the residual fragment rate of 38%. This was in a series from Dallas, from Peggy Pearl, and it was on CT scans and showed a residual fragment rate after retrograde intrarenal surgery that was, you know, most people would not be very happy with that. I mean, a lot of residual fragments. And we do know from work from a former fellow of mine, Ben Chu, out in Vancouver, that if you leave small fragments up there, many of these patients will become symptomatic, you know, and have stone growth and get into clinical problems. So really it emphasizes we still want to try and have stone-free rates. More recently, Jim Lingaman and Krambeck in Indianapolis have shown us that maybe things aren't as bad as was documented in Dallas, that if you meticulously remove the fragments, that you can get good stone-free rates with the ureteroscope and with the laser. So in this case, you know, it was up around 85% stone-free rate, which we're much happier with that. So back to the original question of, you know, up to what size of stone can we treat in a retrograde fashion with the ureteroscope? So this is probably the best summary. It's a systematic review, so included many publications of stones bigger than 2 centimeters. And what they found was on average a stone-free rate of over 90%, which is quite good. One point to emphasize, a lot of these patients needed 2 operations, so 2 treatments with the ureteroscope to achieve that. But overall, the complication rate was low and the outcomes were pretty good. But I think here in this slide, we see that most of the major complications were in stones bigger than 3 centimeters. So I think that starts to give us a perspective that maybe 2.5 to 3 centimeters is the limit currently of what we might achieve with the ureteroscope. So I think this is very important information. To finish off here though, I want to talk about a competing operation now for flexible ureteroscopy, and that is mini percutaneous surgery. And the history of PCNL is interesting. It also started over 40 years ago. First cases were done in Sweden. Then Arthur Smith and the colleagues at the University of Minnesota advanced things from there. And percutaneous surgery has undergone a lot of innovation in the last few years as well. It includes tubeless PCNL, smaller instruments, and doing mini PCNL. So it's become much less invasive than it was, and is now competing with ureteroscopy for even smaller stones up in the kidney. And it's not too often in urology where we have 2 operations that are very different, ureteroscopy, percutaneous surgery, you know, competing now for the same patients, you know, 1 centimeter stone or 1.5 centimeter. So it's a very interesting phenomenon that is occurring here. And mini perc, so-called, has been around for at least 20 years. And initially, there was not too much interest in this, but in the last couple of years, the interest has exploded in mini percutaneous surgery. And I give great credit to people from India and from China in particular, who have really advanced this particular operation and you know, built the equipment themselves and have really been determined to advance this. One of them is Janik Desai, who's working through 13 French tracts and much smaller than the usual 30 French, and showing us that what he calls ultra mini PCNL is a very good operation. And Janik likes to show this slide, so do I, you know, with the usual sheath and now with the very small sheath that you can work through, much less invasive, less bleeding, and so forth with a mini PCNL. And there's a whole lot of new technology for this. You know, our usual companies building smaller instruments for mini percutaneous surgery that have really allowed this operation to flourish in the last couple of years. So now we have studies that compare the two, PCNL versus flexible ureteroscopy and the pros and cons of these two different operations. And it's very interesting that a lot of the outcomes look the same. So here we see same OR times, stone-free rates are about equal. And so overall, each of these operations are kind of competitive and look quite good. This study looked at ultra-mini-perc versus flexible ureteroscopy and things like analgesic use and patient satisfaction, no difference between the operations. PCNL took a little bit longer in the operating room. Length of stay in the hospital was a bit longer, but overall it starts to become pretty competitive with retrograde ureteroscopy. An advantage of mini PCNL, and maybe why it came from India and China, is that you can reuse the instruments. So it's probably a less expensive operation than flexible ureteroscopes and lasers and all of the access sheaths and all this other equipment. You don't need that to do a mini PCNL, so it may be less expensive. So this final thing here is a systematic review that looked at all the studies comparing these two different operations, and the outcomes are there at the bottom, that a mini PERC gives better stone-free rates, complication rates are the same as flexible ureteroscopy, and actually the OR time is actually less for a mini PCNL, albeit a little longer stay in the hospital. So it emphasizes again how we have two competing operations for the same clinical problem, a 10-millimeter stone in the kidney. The latest version of this out of China is super mini PCNL, which is done through a very small instrumentation, 8 to 10 French. I've operated with Guo Hujing myself in Guangzhou, China, and been very impressed with the instruments he's developed and how minimally invasive this operation has now become. Patients get up off the OR table, even bypass the recovery room, and go home the same day with a Band-Aid on their back. So it's become a very minimally invasive procedure. And the most recent study that now, retrospective, well-done trial, examined super mini PERC, as I just described, versus flexible ureteroscopy, and looked at the outcomes between those two treatments in 160 patients. And what they found was a lot better stone-free rate with the percutaneous approach, no difference in the OR time, hospital stay, complications, blood transfusion, and so forth. So at least in this study, it looks like mini PERC comes out on top compared to flexible ureteroscopy. So, I think a lot of it, again, will come down to costs, what your training is, what instruments you have, and so forth, which of these will fit in your institution. But both of them, I would say, are possibilities now, depending on your situation. So just to finish off in a few summary points here. So what are some good indications for bigger stones for ureteroscopy? I think, as I described, obese patients, anticoagulated patients, patients you can't get access percutaneously, patient preference, they say, I don't want to have a PCNL. It's this group of patients where I think it fits in quite well. Probably, though, with a limit of 2.5 to 3 centimeters. Some technical tips and tricks for you. If you're going to do bigger stones up in the kidney, you're more likely to use an access sheath to keep the pressure down, improve the visibility. You're more likely to have to use pressurized irrigation, so some syringes or something to clear the field of view. And a good rule that I find is to only work for about 90 minutes. These operations shouldn't really be taking 2 and 3 hours and so forth. I think the sepsis rate goes up. So work for 90 minutes. If you can't do the whole stone, then you have to bring the patient back for a second procedure. And I think with the big stones, you're more likely you're going to leave a stent in afterwards. So what kind of outcomes can the patients expect? I tell them if it's a big stone, it might take 2 operations. It's probable it's less likely you're going to be stone-free than with PCNL. But overall, this is a good operation. The complication rate should be pretty low and equivalent, really, if the stone's smaller than 3 centimeters, to a standard ureteroscopy. So I'll leave it there, and I know we have a question and answer later, and I'm happy to take your questions whenever you like. Thank you again.
Thanks, John, for this nice presentation. That is very exhaustive and very informative. So shall we start asking question, or shall we delay that till the end of the second presentation? We can carry on with question with you, or shall we delay it till the after the presentation of Professor Ezra? نعم. Wait.
We perhaps you do now survey analysis.
Okay, so we, from our side, we will present a survey. It's a kind of questionnaire we sent to urologists in Morocco to have an idea of the common practice concerning how to deal with the urolithiasis. So can you see my, I will first share my screen. Okay, go ahead. Okay, can you see it now?
Yes.
Yes.
Okay, well, I will do the diaporama. Okay, diaporama. Okay, we go. Can you see it now? Okay. So we sent the questionnaire to a number of urologists. Unfortunately, we had only 12 that took part in this survey because maybe for the vacation or some people are very tired. So the first question was about the proportion of the urolithiasis in your overall activity. 81% responded that they have more than 25% of their activity as urolithiasis. The second question was, do you stick to the guideline regarding the management of kidney stone? Always 25%, and sometimes the act off-label 72%. What is your preference at equal recommendation for a stone less than 2 centimeter pelvic stone? Is it SWL, RIRS, or PCNL? 27% PCNL, 27% RIRS, and 45% go to the SWL. If you perform PCNL, which one, standard or mini? Standard is 54% and 45.5% for mini. Do you perform your access yourself, or you get the radiologist help? Most of the urologists, the 100% are doing their access themselves. Which callus you use for access, and lower, middle, upper, or the most accessible? Majority are going for the most accessible, 45.5%. Concerning the staghorn, do you do it yourself or you send to a referral center? Most of urologists, 72%, are doing the staghorn themselves. So. Which instrument use pneumatic or pneumatic ultrasound or laser? It's equally divided. So laser and 36% also for pneumatic ultrasound, and 27% only for pneumatic. Okay, complete clearance. Do you leave a stent? The majority will leave the stent. Tubeless only 27.3%. Regarding RIS, do you use reusable or single? Most of them are using reusable. If you have a stone less than 2%, do you use fragmentation or dusting? 70% use the dusting. At the end of RIRS, do you basket or fragment and leave? 50-50%. So checking the state of ureter at the withdrawal, always the majority are checking 72.7%. This is probably concerning if you leave a stent or not, or the majority are only if there is a lengthy procedure or residual fragment, 60%.
Single use.
Single use. So is it a solution for our current situation here in Morocco? 63.6% are answering yes. The price of disposable flexible ureteroscope is affordable. No, that's the majority are agreeing that the price is still high for this to be a common practice. So maybe this is the last question. So we'll go back. We'll stop. Okay, this is the result of this small survey, and this is it reflects the mindset of our urologists here in Morocco.
But it's representative.
Absolutely, absolutely. So shall we carry on with question, or we'll move to the second presentation with Professor Lezrek?
I think it's better to carry on with questions because the two talks are a little bit different. They are complementary, but they are different. So, what is the preference of John?
Probably. Yes. We'll ask him if he's ready for some question, or will he prefer to relate it until the end of the session.
Do you have some question from the audience?
Professor M.Lezrek, you have?
Not yet.
I don't have no question, yes.
Okay, so just a comment now regarding the mini PCNL and the RRS, they are converging toward, they are, as you say, it's competing for the same indication for small stone. So this is going to be the ultimate referee in this situation will be only the experience of surgeon, the preference, and the cost of the instrument. What do you think, John?
I would agree with that, that's what it will come down to. The one thing I would add is the preference of the patient, right? And what the patient feels. But training, instrumentation, cost, patient preference, because all the other outcomes are going to be the same. You know, we're very close to being the same. Complications, stone-free rates, maybe even. So it requires a very careful discussion with the patient about the pros and cons of both of those operations. But you know, again, I've made the point. It's interesting to see how these two competing things are now in place. And let me just comment on your survey. You know, even though the sample size was small, it's still very interesting information. I think it's encouraging that 100% of people get their own access. That's great. We do too. But you know, in North America, it's still fairly common for radiology to do it, which I don't think is the best way to do it. So it's great to see that in Morocco that people get their own access. That's great. Yeah.
If you mind,
any question? Yeah.
Yes, I have.
Go ahead, Dr. Sarf.
John, for the shock wave lithotripsy, in the French Congress last year, Mr. Traxler talked about maybe that there is a new technology for the shock wave lithotripsy, and this technique maybe will prepare in a comeback. Is there any information about this? Because I think technology may be evolving in the shock wave lithotripsy to come back and to compete for PCNL and the ureteroscopy. This is the first question, if you don't mind.
That's a great question, and you know, it could be that ESWL has reached the bottom where it was going to drop to, and now we may actually see an increasing interest in it for a couple of reasons. One is better patient selection. You know, there was a time when anybody with a kidney stone got shockwave, you know. But now we've learned a lot, you know, Hounsfield units, density, which we measure routinely, skin to stone distance, and we've got pretty good algorithms now to give us better advice on which patients are good. So selecting the right patients, your outcomes will be better. The technical part of doing it is important too. It seems so easy to do, but it's like any other operation. If you don't pay attention, you will get bad results. And slowing down the rate of the shockwave delivery is important. It works better when you go at a slow rate of shockwave delivery. And being very careful with the imaging to be sure that you're on the stone when you treat it. There was a great study from Japan a number of years ago. They went back to a group of urologists and trained them again how to do good shockwave lithotripsy, and the stone-free rates went up like 30%. So patient selection, training, paying attention, and then there could be evolutions actually, as you've said, in the technology, right, that improve the ability of shockwaves, and in the imaging that guides the shockwaves, and respiratory gating, you know, to improve the results. So if you put all that together, we shouldn't completely throw away shockwave. It could still be, you know, a good treatment. And it's also interesting how reimbursement drives a lot of what gets done in certain places, right? How the physicians get reimbursed for what they do, ureteroscopy or shockwave, and so forth. So anyway, that's another factor that seems to be in place. So I hope that answers your question.
Yeah, I think
do you have your? Okay, go ahead.
Must not forget the SWL, because if not, maybe radiologists will take place and lose it. So we have to stick to this technique anyway.
Mm-hmm.
Yeah, for John, do you have yourself any experience with thallium laser? This is the first question. Second, if the sit-in remain the same as the holmium laser, so that is to say, dust-in, fragmentation, all these things will remain the same for the.
Right. Yeah. So interesting. My only experience right now with the thulium was in India, where, you know, I do a lot of international training courses, and I very often operate, you know, when I go various places. So I used it with Ravindra Sapnas, you know, who works with Mahesh Desai. I don't know, it was before the COVID crisis, so at some point in the last year in India, and I did several cases, and I was very impressed. We are expecting it here at our hospital very soon to start using it here, but my experience was in India. And, you know, it operates at a very high frequency, up to 2,000 hertz, right? And it will break up very hard stones very rapidly. So it's the efficiency of it, which seems to be the benefit for the thulium laser.
So it will encourage you to take on bigger stone.
Possibly, it could, yeah, it could move forward even further RIRS for stones because of its efficiency.
Just one more question: if you basket after the fragmentation of stone, you always try to get stone free by basketing.
Okay, so there's probably two general techniques. One is fragmenting or dusting the stone. And usually leave a stent and let the fragments pass, or basket out all the fragments. Our approach generally is the first approach, the fragmentation of the stone without basketing.
Fragment and leave.
Correct. Yeah.
Not fragment, dust and leave.
Well, it could be either dusting or fragmenting. We use both. You know, I think in the ureter, if the stone you're treating is in the ureter, patients will usually pass those fragments close to 100% of the time.
Problem. It's the lower calyx or the.
Correct. So it depends on the stone location.
Zintin, there are two questions in the chat.
Okay.
Two questions, yes, from the audience. The first one, talking about how to manage urinary infection when doing flex ureteroscopy. I think it's contraindicated to do flexible ureteroscopy when we have urinary infection. You have not to manage, you have to treat first. I think it's obvious. You can add more if you like, Mr. John.
Yeah, a couple of points to make there. One is, you know, you should get a culture on every patient beforehand to make sure the urine is sterile. If the culture is positive, they should be treated with antibiotics, usually for a week, to try and clear the infection. The other point is, if you have a septic patient, or if you put up a guide wire and you see pus, you know, coming from the kidney, you want to back out of that, just put a stent, treat the infection. So don't do ureteroscopy if there is frank infection going on. So those are a couple of you know, practical points that I'm sure people are following. This is like bread and butter. We call it urology. But even with that, I'll tell you, I had a mortality myself about 3 years ago in a patient who had a routine 10 millimeter renal pelvic stone, had a positive culture, treated with antibiotics, then a negative culture, brought to the OR, straightforward case, took 45 minutes, left to stent him afterwards, and you know, immediately got into trouble with sepsis in the recovery room, and died of multi-organ failure. An elderly woman with a lot of comorbidities. So even when you do things perfectly, things can go wrong, right, with sepsis and so forth. So we all have to be aware of that.
Okay. There was a second question.
Yes.
From the audience, yeah. There was another question from the audience, or no?
Yes.
No?
Yes.
Okay. What is that? Can you
I think,
go ahead?
Asking about the cost of flexible ureteroscopy versus PCNL.
Right. Yeah, I see the questions here. So flexible ureteroscopy comes with a lot of associated costs, whether you use reusable scopes or disposable scopes. You know, the reusable ones you can only reuse a certain number of times, maybe between 10 and 25 times, then they break, then they have to be repaired. And the instrument you get back after the repair never lasts as long as when it was new. So reusable scopes are actually disposable too. It's just how many cases they will do. So you've got the cost of the scope, the cost of the laser fiber, the cost of the guide wires and so forth, the stent, and you add all of that up and it's a pretty substantive cost. Whereas a mini PCNL, a lot of that can be reusable equipment. So, you know, standard rigid scope and so forth. So I think in most environments, mini PCNL is going to be less expensive than flexible ureteroscopy is currently.
Do you use pump, or you rely on gravity only?
So we start out always with gravity and see if, you know, if that will clear the field of view. If it does not, then we will go to a syringe, you know, kind of a pump. So it's just a mechanical syringes is what we use, not a infusion pump.
Regarding stenting, is it systematic, or you have residual fragment or lengthy procedure?
Right. So we did the first randomized trial of stent versus no stent for ureteroscopy. And we don't routinely stent everybody. So patients, though, who should have a stent are, if you balloon dilate the orifice to get up, if it is a very impacted stone and a very large stone, if you have a ureteral perforation, so any injury to the ureter, solitary kidney, history of infection, you know, all of those are good reasons to leave a stent in. The patients we don't stent are those who maybe have already had a stent in because the ureter then is dilated. Those are good cases to do without a stent. You know, no injury, no solitary kidney, all of that. And if the stone is not too impacted and the caliber of the ureter looks good, most of those patients will do okay without a stent.
Oh, great. Concerning the calyceal diverticulum, which way you go?
For calyceal diverticulum. So
Stone.
Yeah, the diverticular stone, I think is the question. So most of those I would do percutaneously, but we look very carefully at the CT scan beforehand. 2/3 of diverticulae are posterior in the kidney, and I do all my PCNLs in the prone position.
Yeah.
So if it's in the 1/3 though with an anteriorly placed diverticulum, then I would do ureteroscopy. It's a ureteroscopy. But most calyceal tics that are in a posterior location, I would do them percutaneously with a direct puncture into the diverticulum.
Yeah, great. So shall we move to the next presentation or any more questions?
Another question.
Yeah.
Yes.
Go ahead.
Before I'd like to add another question, but the guideline in the United States, you have to stick to the guidelines or not. And if you don't stick to the guidelines, have you to explain that to the patient? And what is the consequences in case of complications?
Okay. Well, probably the best way to answer that, even the word guidelines, that's different than policies, right? So a policy means you must do, whereas a guideline is a good recommendation. I'm sure we could look up the definition of a guideline. So it's a good recommendation and so forth. So we do know that a lot of people don't rule by rule follow the guidelines, but I think they provide us some good parameters, if you like, about how to treat people. So I don't think any of us want to be a person who's way outside the guidelines 100% of the time. Right? That's not a good place to be.
Yeah.
You want to be doing what's commonly practiced and acceptable in your environment and so forth. You know, those big staghorn stones I showed in my talk. If somebody's approaching that with the ureteroscope, that's a long way outside the guidelines, right? So I think there is a range of flexibility, to put it that way, in the guidelines that's reasonable. That's what I would say.
Okay. Thank you, Mr. John, for this presentation. This is really interesting. And now, if you'd like to move to Mr. M.Lezrek Mohammed. And before I want to introduce my friend, M.Lezrek Mohammed, a pioneer and revival of endourology in Morocco. He has a special expertise in PCNL with development of his proper techniques and development of simulation models, which are cheap and genius. Have many tips and tricks that you can see in his channel on YouTube, and also doing a voluntary works PCNL, promoting PCNL in Morocco and the many national and international live surgeries. I thank Mr. M.Lezrek for the voluntary works, and I invite him to share his experience with us. The screen is yours, Mr. M.Lezrek.
Thank you. Thank you, dear chairman. And I want to thank you for inviting me to participate in this wonderful webinar and to be among such great faculties. So my talk will be mostly a technical talk about some tips and tricks that we use in our daily practice and how we had spread PCNL to most of Morocco. and I had non-disclosure. Also, before beginning, I want to invite you to participate to this symposium. I am the chairman of SANTU, which is a symposium on affordable new technologies in urology. It will be for next year, because this year there will be a webinar, and I don't have the link yet, and I will share it with you afterward. But for 2021, I invite you to participate, especially to the competition Bantuk, Best Affordable New Technologies, with prizes from $2,500 to $1,000. I will be happy to have one of my friends winning one of the prizes. Here are the photos of last year's, and the rules, you will find them in SIU website. So the history of PCNL. John has already talked about Fenstom and Johansson, and the first reported nephroscopy was through an existing nephrostomy tracts back in 1941. But what do we have to learn from history? If we can analyze this, we will see that both those authors had no technology or special equipment. They just had an idea. This is creative thinking, an idea. And also they had the courage to use this idea. They had used equipment in a different indication. So they had maximized what they had at hand, and also they had shared their idea by publishing it. They had only publishing in the time. So if we can do this 3 or 4 rules, we will be doing great. So the history in Morocco, the first PCNL was performed by Professor Ben Shkroun back in 1986, but until the end of the 90s, most PCNL was mostly done in Rabat, and with selection of cases, they are continuing open stone surgery for larger stone. So there was no resident teaching. So the experience was not largely spread. Also, many urologists in Morocco were afraid to perform PCNL. They had seen complication, or they heard about complications. Also, there are some killing ideas and paradigms, like never to perform PCNL if you don't have an interventional radiologist. Also, you have to have many equipment, or all the equipment. And like if you don't use the balloon for the tracks, it is very dangerous otherwise. Also, there are some economic limitations. So PCNL has the same gradient payment as TURP or adenomectomy. So it is not cost effective, especially in private sector. So, and also it's the urologist that had to provide equipment, nephroscope and all the equipment. And most think that if I tell the patient a higher price, he will lose the patient. So he passed to open surgery. Also in public hospital, the staff is scarce. So sometimes there is just one nurse in the operating room or no nurse, and the equipment is incomplete. So the urologist, if he wants to learn, he has to provide the equipment, and the patient cannot afford the consumable. So back in 1997, we had begun PCNL in a military hospital in Meknes. And we had tried to do a Moroccan customization, and we had shared our expertise. So from 1997 to 2019, we have shared our experience with many hospitals, in public hospitals, in teaching hospitals, and in private sectors. So we had developed tips and tricks to adapt to our environment, and especially to economy of time, money, and radiation exposure. And also to show the other users that it is possible and relatively simple and acceptable rate of complication. We had back in our department, we had the open doors policy, and all the urologists were welcome to come and see. So I was the head of the department of the military hospital in Meknes, Morocco. And to promote urology, I am doing almost full-time voluntary work since 2011. I am sharing through social media, YouTube, LinkedIn, and also coaching and supervising training for small groups of urologists in public hospitals and in private hospitals. Also, I had done many workshops in Morocco, in Africa, and Pakistan, India. So most of the idea that I will present are teamwork. This is a gathering of ideas from brainstorming with many friends and colleagues. And you know the necessity is the mother of all invention. So what is PCNL? If we can separate PCNL to two procedures. There is the traction, the creation of the tract, and the stone, the treatment of the stone. So what do you think it is most important?
All is important.
Yes.
All the steps are important.
Yes, all the steps are important, but most urologists think that the tract and the puncture is the most important. I don't agree with them. Of course, if we had access of filler, there is no access, there is no PCNL. But the goal of PCNL is to remove stone, and the patient has come for you and accepted the procedure for you to remove the stone, not just to have the access. So access is just like a toll to pay or a fee to pay to enter a school or a club. But have you studied in the school? No. So so we have to teach and learn. And now it's better to start with simulation. So there are virtual reality simulators and also biologic models based on porcine kidney. But we cannot have both this in Morocco. They are very difficult. So we had this idea to use a glove model. So glove is filled with saline, and we use the tip of the glove as a calyx. So it is very good for learning puncture. But this model is limited. It needs a C-arm, so it has to be done in the operating room or in the radiology department. And we cannot do it in workshops, in meetings. So I had this idea to use only light, like shiny shadows plays. So I was in a workshop with my friend, Professor I.Sarf, in his department in Marrakesh, and we had this retro projector, and one of the urologists with us said, you can use this. This is a very strong, powerful light. So the finger is filled with the air and is installed above this retro projector, and we can do the training by puncturing the tip of the glove. I was also in another workshop and we didn't have this retro projector. So we have this idea to use the torchlight application of a smartphone, and it had worked nicely. And we can also shorten the fingers of the glove to have this like hydronephrosis. So now we are master of the puncture. So we have to train also for dilation. So it was already reported to do the dilation on a watermelon by a urologist from Sri Lanka. And this is my kitchen. My wife was preparing couscous, and I had this small fragment of pumpkin. And I thought, yes, this is a nice idea. We can use it instead of a watermelon, especially in the winter when the watermelon is not very common. We also, we had a model to train for nephroscopy and stone location. So the glove is filled with saline with a non-plus sheath, and we can train for nephroscopy, for exploration, extraction of the stone, fragmentation. We can also train for flexible on this model. basket. We have also, yes, do you have a comment? Yes, we have also an idea about micronephropexy, and we use this optic view from Cook Medical with the 25 centimeter 16 gauge prostate biopsy needle, and we also train on a glove model. Here is the needle, homemade needle. Introduction. Exploration of the glove and fragmentation of the stone. So I think they are very cheap and very effective models, and we have to do our best to train on them. So we have to plan for the procedure, and it is better to have a good imaging for better information of the patient and to choose the best track to have the more stone free. So in this case, unfortunately, mostly the patient that I see come with just this CT scan. So with this CT scan, I cannot decide which calyx to access. So it is preferred, like you see here, there is a horseshoe kidney with this staghorn. So I think the best access will be, I will do the best access will be through the upper pole, and I think with the help for flexible for these stones, I can remove most of this stone. What I prefer is to have good radiology and reconstruction like this. So we have this large stone, pelvic stone, and there's smaller stones in lower. So what will we choose? What is the best access? So I try to do this this preparing and this work with my resident and with my friend. If we do access from here, we can access a little bit of the stone and the OPG and the ureter, and not here. And if we access here, maybe we cannot control the OPG, and you see that is very large. So I will prefer to access a middle calyx, and we can treat all the stone, have access to the OPG and the ureter, and also this lower stone. However, from this axis, it will be difficult to control this calyx. So, and also in the AAU guidelines, it is recommended to have a contrast study, not just a CT scan, non-enhanced CT scan. Also, we have some people prepare for this the procedure by doing 3D printing of the pelvic calyceal system and of the stone. Some use plasticine, but since sometimes you cannot have this technology, so just a good CT scan with 3D reconstruction is sufficient. But we have to use what we have. If we have to do a good analysis of the image, and before the procedure to do this creative visualization technique, and with like seeing with the mind's eye, and to do this intellectual 3D reconstruction. And I think it is very efficient in PCNL, but we have to do it also in all the procedures. There are some examples. I will skip them. So you know very well the rule of radiation protections, and you know better than me these rules. But what I can add is for maximizing the distance, instead for the patient to hug the CR, it's better to do it in lateral position with an extended hand. So you see my friend, Dr. Tazir, head of the department of the urology department in Al-Ghassani, in Hospital Al-Ghassani Fas. And when he extends his arm, he is far from the radiation exposure in the green area. So, and also I had most urologists use fluoroscopy to do intrarenal orientation or exploration. I don't agree with them. You have to maximize endoscopic exploration and use fluoroscopy until the end. So the first thing that has changed our practice in weakness is the position. So we had started with the prone position, and we need this change of position from the lithotomy position to the prone position. It took us mostly more than 45 minutes. So since 2003, I am using a lateral modified position. It is not derived from the supine position, but from the lateral position. So the patient is installed in a lateral position with the shoulder is blocked with elastoplast band. Then the pelvis is turned in an oblique position, and the lower limbs are opened and bent in the lowest possible position, allowing access to the lower and upper urinary tract. So there is a gain of time, just one position, and almost no time between the ureteral catheter and insertion and puncture. And also there is economy of drapes. And also in this position, the M.Lezrek sheet is in dependent position. So stones, there are less pressure in the kidney, and also stones mostly spontaneously goes out from the M.Lezrek sheet. Also, it gives us a good access to UPG, where we mostly now we perform percutaneous endopyeloplasty. You see stones going outside spontaneously. We had used the same position in a small series of pediatrics population. The other technique that had helped us to progress in PCNL is to simplify the monoplane fluoroscopic puncture. So in this puncture, we are oriented in the cranial, caudal and frontal plane. This is what we see, but we cannot see the depth of the puncture. So how we do it? So this is what we see, and from what we don't see, we blindly try to find the kidney from going from down to up until kidney moves. Well, I will show it to you in a glove model. So this is what we see, but blindly we move the needle from down to up until it is in front of the kidney. And in front of the kidney, when we see that the calyx is moving, we do our puncture. Here, the needle is still outside the parenchyma, and we see an indentation of the calyx. So most of the time, we prefer an upper pole access when the location of the stone permitted. So how do we do it? When the kidney is high, we use a needle renal displacement technique by puncturing a lower or middle calyx. Then we insert a guide wire, and by pushing the needle in the cephalic direction, the kidney is moved caudally. So sometimes we have a gain of few centimeters. Of course, we have to use a trocar needle, not a Shiba tip needle. And here, a stone in the upper calyx, puncture of a middle calyx, guide wire is inserted. Then by pushing the proximal end of the needle caudally, cephally, the kidney is moved downward. And here also we use this technique to immobilize the mobile kidney. So with just one needle renal displacement, we have this, we have gained few centimeters, and we can use another one and we can gain more. Also with this technique, the axis of the kidney is changed from the upper calyx is moved more laterally, so more accessible to a puncture. Here you see the upper calyx is here, and here it is more accessible. So since 2004, we are using the one-step or one-shot dilation. So directly to 24 to 30 in the beginning, and now mostly to 24 French axis sheath. I recommend to for my student to always insert a safety guide wire, but to do it with no cost, we use either a small segment of the coil house in the guide wire or through the implant dilator, or we can do it also outside the small fascial dilator. Now, mostly I am using this technique, which is similar to the ureteral axis sheath with the parallel guide wire. So a slit is performed on a ureteral catheter. The guide wire is inserted in the slit. By pushing the dilator, it will dislodge the guide wire. So here in a patient, the guide wire is stocked in its housing coil, and the dilation is performed beside or parallel to the guide wire. Of course, you have to have a stiff catheter. So how to remove blood clots or pus if the urine are not clear, or small sand. So what we do is to adapt the nephroscope, the aspiration tube to the nephroscope operating channel, and it is the best way to begin the procedure to remove all the clots. Small fragments less than 4 or 5 millimeters are extracted through the nephroscope. Larger ones are extracted through the implant sheath. I think there is no better way for matrix stones. So this position allowed us to perform simultaneous ureteroscopy, rigid ureteroscopy or flexible, and PCNL. And we think that with this position, we can do antegrade rigid ureteroscopy. We can descend very low in the ureter. Also, it allows two-team approach, and in 2 or 3 patients, we have performed also TURP and PCNL. It is the best way to treat large stone incrustation of a WG stent. And here we had the meeting of rigid ureteroscope and rigid nephroscope in the ureter, and they are shaking hands. Sometimes the rigid ureteroscope can reach the upper calyx. So here to approach simultaneously, and for second or third puncture for a large stone, since 2004 we are using mini tract using the rigid ureteroscope. So after puncture and insertion of 2 guide wires, the rigid ureteroscope can be used simultaneously if possible. Hair progression in the retroperitoneum. The stone is located in the calyx, then it is moved, pushed toward the renal pelvis, where it is extracted through the larger axis. lately we are using a drinking straw. Here it is a drinking straw of 13 or 14 francs with the rigid ureteroscope, and we have done a small series of mini PCNL like this. Can you tell me what's my remaining time? Dr. Zin?
No, Dr. Sarf, do you?
Sarf, Dr. Sarf?
Right.
I think that you may have 10 minutes.
10 minutes.
Yeah.
10 minutes. 10 minutes.
10. So I was in a workshop where we were planning to do an percutaneous endopuloplasty, but when we entered the kidney, we had this bleeding from the renal tunnel. So what will you do? Will you stop here? Will you do? So we think it's better to do coagulation of the tract. So we didn't have a special electrode. So we use this ureteral catheter here, cauterization of the tract. This is ureteral catheter from Roche with this large brass tip. And this is before the coagulation, and this is at the end of the procedure. Sometimes during the dilation, the kidney is pushed, but by just the dilator. You have seen the kidney was here and it is pushed. So to avoid this, we continue the dilation under direct vision with the nephroscope and the bipronged forceps. Here, the parenchymal channel with almost no bleeding. It was very thin, and here a normal parenchyma. But when we enter the kidney and the implant sheet is installed, there is no bleeding. I will talk to you about special complications. So this is the case of patient with who had 1 year ago open surgery for Staghorn calculi, and she had the full residual stone. So we cannot do flexible. So PCNL was performed, and we could not move the kidney. So we had done an intercostal access between the 11th and 12th rib and 10th rib. The stone was found, but when trying to extract it with the flexible, it stuck to the calyceal entry. So we had used some force, and the implant sheet and stone was pulled outside the kidney. We had tried to remove it, which you must not try, but the stone was lost into the tract. So we lost it completely. We didn't find it, and we do fluoroscopy, and the stone was into the thorax. So what will you do? So it was a very difficult decision, and we had tried, and we have found the pleural access, and we were lucky to find the stone after a suction of this liquid, and it was extracted. This is stone between the pleura and the lung. So we were doing a PCNL in private hospital, and we didn't, it was a large Staghorn calculi, and we had this remaining stone in the upper calyx. We didn't have a basket, and we cannot remove it with suction or by flushing. We didn't want to do another access, and also the flexible nephroscope was not available. So we had this idea to use a floppy hydrophilic guide wire, and it was weaved into a basket. and here introduced into the kidney. And we were lucky, we had managed to move the stone and to extract it. So afterward, we had thought about what can we use instead of this floppy guide wire. So we can use a nylon suture. So basket is weaved from a nylon suture. We use a coaxial WG pusher. And we had used it in our glove model. And if you have some other ideas, I am open to it.
Right.
Or you can submit it to Bentuk. So we were doing PCNL, and this we had this large outflow from this rubber seal, and we didn't have spare. So we had this idea to use either a small patch from the rubber seal of the head of a syringe, 20 milliliter syringe, or we can use it wall, and it works perfectly. And since that day, we use only this in this department. The same thing for the flexible. We don't have this fancy ureteral seal, and I think it costs between $20 to $30 here in Morocco. So we had the idea to use this injection port of serum bag. And no more outflow. So how to adapt the ureteral catheter to a drainage bag? Mostly we don't have these fancy adapters. So there are many ways to do it through the funnel shaped end of the Foley catheter, or by using this injection port of the serum bag. You can also use at the end of the procedure, we remove this flexible valve, and it is very effective.
Yes. So Zraq, can you conclude?
Yes. So I told you already about the micro PCNL. Because last time you had told me we had about 42 minutes. So that's why I had prolonged, made more slides. So Bernard Shaw has said, there is no progress without changing our mind. So we have to work on this. And my take home message is to do exploration for stone fragment is as more important as percutaneous access. But I think Professor Sarf will talk about take-home message. So I skip this, Professor Sarf.
Yes.
So I insist PCNL is easy, very easy, but you have to try to learn it with rigorous technique. Like I say, crossing the street is very easy. But if you are not rigorous, it is very difficult with a lot of bleeding and a lot of mortality.
Okay, thank you very much, Mr. Zraq.
So,
you can conclude. Yes, I'm
yes, yeah. So thank
go
you.
on.
And I had a lot of tips and tricks on my YouTube channel. Thank you.
I know that you are a box of tips and tricks, you know.
As a troubleshooter.
A box that, you know, like the box of Alibaba or something like that.
Any comment from Professor John?
Yeah, thanks. That was a great talk. You covered a lot of topics, but there's a lot of innovation there. I'm very impressed with the model that you've developed, and also at your determination to spread the technique. You know, both in Morocco and
Thank you.
to other countries.
Developing country as well. Yeah.
You to be congratulated on all of that. Very great
Thank
work.
you. Thank you very much.
I want just to add to precise something that Mr. Lezrek, because we work together, he adopts technology, but he travels a lot in Africa, and sometimes, and also in some places in Morocco when there is no means to practice PCNL, and that's why he innovate. I mean, this innovation are done in case of need, but Mr. Lezrek use technology and use staffs from.
Yes, necessity is the mother of invention.
That's right.
I think it's great, and maybe someday I will have the chance to come and work with you there in Morocco. Or
yes, it will be a pleasure. And also, you have to be with us in Santu. In next Santu or next one.
I will certainly try and do my best. And
yes, thank you.
You send me the details.
Thank you.
Thank you.
Thank you.
Yeah.
So there is no question from the audience. So
carry on with the take-home message, Professor Sarf.
Okay.
Yes.
I can't use the sharing from my PC because I have a problem in my PC, my computer. So I think I give my presentation to Msharqi. Would you please? Yes, thank you.
Okay, it's there.
Okay. So move to the next one. I think take-home message for Mr. John. For symptomatic patients with total no lower pole stone burden less than 20 millimeter, he advocates shockwave lithotripsy versus uteroscopy, strong recommendation, evidence living grade B. And for symptomatic patients with total no lower pole stone burden more than 20, he advocates PNL for a strong recommendation, evidence level grade C. And the explanation why for the first case, stone-free rate acceptable via shockwave lithotripsy and uteroscopy with less morbidity. But in case of more than 20 millimeters, I think PCNL has a higher stone-free rate than both shockwave lithotripsy and or uteroscopy. Next one. Next one, yeah.
Yes.
For a patient, not a good candidate for PCNL for many reasons, whether body habitus, contractural flexion deformities, anatomy, renal or collecting system deformities, or anticoagulation or antiplatelet therapy. I think in this case, we can offer staged ureteroscopy. Next one, please. Next.
Mm-hmm.
Next slide. Next slide. Here we're talking about the innovation in the laser for the helium. Nowadays, we talk about MOSES technology. It's a good technology because developed by Luminous, laser pulse first separates water. The so-called MOSES effect that we all know, MOSES separates the water, thanks to God, and then delivers the remaining energy toward the target stone. And the advantage that gives less energy lost, and the laser transmission is less dependent on fiber stone distance. For the thulium laser, it produces a continuous 2000 nanometer wave. Energy is absorbed only by water, and depth of penetration is 0.25, has less heat dissipation compared to helium, which requires less cooling, leading to a potential to operate at a high power range, more than 50 watt, and high frequency, and reach up to 2000 hertz. I think for the thulium, as Mr. John said, practice it in India. It's promoting. It's for a technique for fragmentation. Okay, next slide, please. Next slide. Here, the effect of ureteral access sheet on stone-free. There is a debate here because there is two studies. The first one showing that the advantage of the ureteral access sheet give more stone-free rates, but in the French study, there is no difference in the stone-free rate. But anyway, as Mr. John said, that the ureteral access sheet is indicated in case of big stones in the kidney. Next slide. Next slide, please. Here, the complication of uteroscopy classified by the modified Clive and gradient system. Hopefully, there's no big complications, only 50%, and mostly grade 1 and grade 2. But the most common complication that we must be fear of is sepsis. It's rare, but serious complication that can cause death. I think not doing flexible uteroscopy in case of infection. You have to treat infection first because the complication could be death in case of infection or sepsis. Next slide, please. The long-term risk of ureteral stricture after high-grade ureteral access sheath injury is similar to that of ureteroscopy done without a ureteral access sheath. This is, there is no big complication with the access sheath. Okay, next slide, please. Here's a very interesting slide. The endourologist must take care of the pressure inside the kidney. And as we see here that the baseline renal pelvic pressure is 10, but it could be 35 in case of ureteroscopic procedure and can increase to 50 in case of fragmentation and also to 2080 in case of forced irrigation. And we know that the high pressure is deleterious for the kidney. So the endourologist must take care about the pressure. Next slide. Moving to PCNL, there is a big evolution and innovation in the PCNL from standard to mini to ultra mini and micro PCNL. And the micro PEC is safe and effective for renal stone less than 1.5, as showed at prospective matched comparison between ultra mini PCNL and flexible uteroscopy. They are comparable. There is no difference in operative time, hospital stay, and complication rates and blood transfusion. And that's maybe give the possibility for countries like Morocco, and this technology is developed in India because the PCNL, the micro PCNL, is less expensive than flexible uteroscopy. So this technology, this technique is interesting for us in Morocco. Next slide, please. For the flexible ureteroscopy and laser ureteroscopy for stone more than 2 centimeters, it's possible. The average stone-free rate is about 93.7%, and overcomplication is higher comparatively to other indication is 10%. And the indication for ureteroscopy for stone more than 2 centimeters, as we know, in case if we can do PCNL, obesity or coagulation, deformity, other medical comorbidities, or patient preference, maybe concomitant ureteral stone or failed PCNL, access PCNL, or in case of renal anomalies. But you have to know that outcomes more likely to require second procedure of ureteroscopy. Next, please. Next, please. Now moving to the take-home message of M.Lezrek. Next, please. Next, please. Yes, PCNL, as M.Lezrek said, is easy, but we have to master a rigorous technique. And the exploration of stone fragmentation is as much or more important as percutaneous access. Learning and acquiring skills on models, even the cheapest, is possible. Next slide. Or planning for procedures with good image and 3D reconstruction and thorough analysis of the image and mind visualization, as explained by Professor Lezrek. Next slide, please. All the positions are better than open surgery, doing pros or have pros and cons. You have to adapt the position and technique and equipment used to your condition. So for Mr. Lezrek, everything, whatever the position, but not doing an open surgery for the stone. Better to train doing access in different position at least once in a lifetime. You might need it. Example, problem of ureteroscopy of rigid renal retrograde intrauterine surgery, need a puncture in supine, same position as ureteroscopy position, an integrate guide wire or a nephrostomy. So you have to master all the position. And stressful supervised teaching and learning is mandatory. A large knowledge of technique, tips and tricks for economic use of equipment, overcome difficult situation, cultivate idea, tips and tricks, and especially sharing them. You have not to keep them. I think that's the last slide. Thank you very much.
Stop the share.
I hope that I have summed up thoroughly the ideas of both presenters.
Thank you. Thank you, Professor I.Sarf. Any question? Nothing? Zindin?
Okay, you can conclude if you think it's okay. It's quite clear.
Mr. President of the Moroccan Association of Urology, Mr. Shrok, you have the honor to conclude.
Yeah, thank you, Professor I.Sarf. Maybe it was an interesting webinar on urolithiasis. I think we can never say too much about the urolithiasis. Thank you, Dr. J.Denstedt, for your participation. Maybe it is the first collaboration with l'AUA, and I hope it is not the last. Thank you, Professor Lezrek. Thank you, Mr. Moderator, Professor I.Sarf and Dr. Aboulfadl, for your successful moderation. Thank you, AstraZeneca. Thank you, Yasmin. Thanks, Azim. Our webinar series will continue in September. Dr. J.Denstedt, I wish to see you again in Las Vegas in 2021. I wish you all a good vacation.
Great. Thank you very much.
Thank you very much. And
Thank you very much.
Thank you
Have
again.
a good night.
Yes.
Bye.
John.
Good night.